Hi, I'm Danielle Jacobson, and today I'll talk to you about research on Canadian law and the reproductive healthcare experiences of women with female genital mutilation and cutting, or FGC. The manuscript on which this presentation is based is part of a larger program of research. And at the outset of this larger project, there was a lack of recent research on the healthcare experiences of women with FGC in Toronto. This was also an area that I heard women with FGC themselves say at community meetings needed improvement. For example, across Western countries, women with FGC have been reported to experience adverse delivery outcomes and interpersonal emotional obstacles during care. We know that during appointments, women have felt exposed, stigmatized, and afraid. However, it's not currently known what it is about the healthcare encounter that leads women to feel this way. Other studies indicate a lack of training for providers on FGC. And while there's room for creation and improvement of training, it's not clear how these kind of institutional factors organize providers' clinical work. So we used institutional ethnography, or IE, to investigate the factors that shape women's reproductive healthcare experiences in Toronto. And this critical social approach allowed us to understand a particular group of people's experiences in a particular institution, place, and time. And across the larger project, we found a specific set of social relations that shaped women with FGC's reproductive healthcare experiences. And today, I'll hone in on a subset of our findings surrounding the law specifically. Included in this study were 8 women with type 3B FGC and 7 Toronto OBGYNs with experience treating this population. Women with FGC were between the ages of 25 and 70, originally from Sudan, the Gambia, Somalia, and Kenya, and doctors were between the ages of 35 and 75. Most were women and originally from Canada, and all received some part of their medical training or education in Canada. To conduct this research, we used one-on-one, in-depth, qualitative interviews with women with FGC and OBGYNs about their reproductive healthcare interactions. And once we had an in-depth understanding of participants' accounts and how some of their concerns were shaped, we focused our efforts on indexing and writing as analytic tools. We did not enter into the research with the goal to examine policies and legislation. But from talking with women with FGC about their healthcare experiences, we learned that they felt excluded because they were unable to access clitoral reconstructive surgery. One woman described how she felt unable to exercise her right to bodily autonomy because of her lack of access to this procedure. And what prohibited women's access to the surgery was it not being covered by the Ontario Health Insurance Plan and them being unable to pay for it out of pocket. When we asked OBGYNs about this, we learned that they had not been asked for clitoral reconstructive surgery. However, they were asked to perform a different genital surgery that alters the labia called reinfibulation. This is illegal in Canada. Now, doctors were not in favor of reinfibulation, but they did question if it was ethical to prohibit an adult from reconstructing their genitals to what they considered as normal, especially when the law allows other cosmetic surgeries that alter the labia. So part of future work here may be to develop greater clarity on what constitutes both bodily harm and reconstructive procedures. Doctors' discussion of what was legal led us to the particular law against FGC, Bill C-27. This has the mandate to protect women's human rights and also entitles women to normal vulvar appearance and function, but does not define what is normal. Instead, there's an implicit assumption of normality based on bodies without FGC in the Western context where the law was made. So this law limits what adult women can do with their bodies, categorizing only particular genital procedures as mutilation. So this limitation of what adult women can do with their bodies was reflected in Ontario health insurance policies that did not cover women with FGC for reconstructive surgery. So this influence reaches into participants' everyday lives, making women feel excluded in their healthcare system encounters and presenting ethical dilemmas for doctors.